We are live.
Good evening, everyone, and welcome to the 100th episode of iFocus Online. And we're here for the masterclass on glaucoma. And today we have with us Professor Sanjay Asrani, sir. And I request Dr. Vanita to please introduce, sir.
Thank you very much, Rolika. It gives me great joy and pleasure here in this 100th episode, a great landmark indeed, with a very special guest. Dr. Asrani, Sanjay Asrani, is our extraordinary guest in this 100th session of PG teaching, both indeed praiseworthy. Dr. Sanjay Asrani was completed his MBBS from GS Set Medical College in India in 1988, and his residentship at Duke Eye Center, a fellowship in glaucoma there too, in 2001. And he completed a research fellowship as well at the Wilmer Institute, Johns Hopkins. It is no surprise then that he's a dedicated researcher and has published widely in his fields of interest, which include imaging of the anterior segment. And I believe he has published a paper on the bleb grading system as obtained via ASOCT. And he has great interest in imaging of the posterior segment in glaucoma as well, newer surgical devices, as well as techniques of drug delivery to the eye. He has received several grants and has been the PI of the clinical trials called Mercury and Rocket trials, both of which have looked into the ROC inhibitors, the newest category of drugs that are available. Mercury was, of course, with Rocklatan, meaning it's fixed drug combination of netarsidil with latanoprost versus individual components, and the Rocket trials were when it was compared to timolol, beta blocker. Of all the work that he has done, I feel his outstanding work is studying these hidden pressure fluctuations. Perhaps he was the first to suggest home tonometry and delivered it, not just suggested, at a time when not very many were available commercially to detect IOP fluctuations, when office intraocular pressure was within normal limits, but still patients were progressing. I've had the pleasure to hear him live right here in Hyderabad, and this stellar work that he published in 2000, in the year 2000, has till date had a phenomenal greater than 1,000 citations. I understand when he's not working, he enjoys traveling, which I believe is not possible right now in the pandemic, maybe in the near future, but he also likes spending time with his dog and enjoys listening to Indian classical music, which I believe will stand him in good stead during the pandemic. With these words, I would like to invite him to deliver his talk on retinal nerve fiber layer, interpretations, as well as techniques. Dr. Asrani.
Thank you, Vanita. Thank you very much for your very kind introduction. I am indeed honored and happy to present this talk that is I have created for a broad audience, so please excuse me if there are some very basic things in the slides, because they are for all audiences, that is including residents in ophthalmology. So I'm going to start sharing my screen, and I want to confirm from.
Yes, sir.
You can see it. Thank you. Yes. Thank you. Welcome to everybody, and I thank you for staying up late for this seminar on a Friday evening. For me, thankfully, it is morning here, and I'm able to be wide awake and present this. So As I was mentioning to Rolika, that I am happy to take questions if you want to raise your hand in between, or you can submit them via chat to Rolika and she can keep a list of them and we can discuss at the end. Without further ado, I'd like to talk to you about retinal nerve fiber layer in glaucoma, techniques and interpretation. If I may say so, this is the basics of RNFL in glaucoma. Of course, we can go into much more detail in further talks, but right now I'd like to start with the basics. So if we presented an optic nerve picture like this to many of my residents and fellows, and ask them if this eye has glaucoma, half would say yes, and half would hum and haw and say, man, I don't know, because the cup is not that big, and the disc is big, and there is no thinning of the neuroretinal rim. And the point is they are focusing only on the optic nerve. I want to confirm that one of you can just say yes or no. You're able to see my mouse here?
Yes, sir.
Okay, good. The what they miss is that we have been so focused on the optic nerve that they miss the big picture. The big picture is that this optic nerve is associated with multiple nerve fiber layer defects that are coming out from various aspects of the nerve. Now, if you concentrate on only the optic nerve and the neuroretinal rim, you will miss these nerve fiber layer defects, which are pretty obvious. So we need to focus on not just the optic nerve, because after all, the optic nerve was the only parameter that was visibly changed in glaucoma using direct ophthalmoscopy, which is what was available to us for the past 100 years. It is still used, that is the optic nerve evaluation, to assess disease severity and to set up pressure targets based on appearance. We then realized, maybe about 30 years ago, that it was possible to see the nerve fiber layer that converges into the optic nerve. And subsequently, about 15 years ago, we realized that it is also possible to measure the macular thickness, that is the ganglion cells, which is the cell body of the nerve fiber layer that leads to the optic disc. Now, description of the optic disc and the cup are like the story of the 5 blind men and the elephant. We are unable to describe it in its entirety. We try to say it's a big nerve, big cup, sloping, shallow, saucerization, focal notching, bayoneting, all sorts of terminology, but it's very difficult to describe it. So we have a host of instruments that have been available to us, starting from the Rodenstock nerve fiber layer, optic nerve head analyzer, nerve fiber layer, GDX, then the HRT, followed by the retinal thickness analyzer, and then the OCT. But we have forgotten now, with the advent of OCT, to use our clinical skills. It works really well, you know, these clinical skills on the days your OCT machine doesn't work. So we need to focus back on the clinical skills, which will confirm for us, not only on the days that we don't have a machine, but also if the machine results are matching up with what your brain can see. Some suggestions in looking at the optic nerve. Let's start with that. Here is an optic nerve where one has to identify the scleral ring. It is this ring that is pretty obvious in this lower half, but once you come to the upper half, it is indistinct. Now, if you can't identify the scleral ring, it becomes difficult for you to identify the size of the neuroretinal rim. The neuroretinal rim is easy to identify from, say, 2 o'clock all the way to 10 o'clock, but then in this upper segment, we don't know where it ends. So these are some of the challenges of examining the disc. We must look for disc hemorrhages, as you obviously saw in this picture, but that are not so obvious in these other images. You can see it's very subtle disc hemorrhages that are present that require careful viewing of the optic nerve. So I encourage all my residents and fellows to look at the disc in careful detail at every visit that the patient comes in, so that you can identify if the disc has a hemorrhage, because typically a hemorrhage occurs at the edge of a previous nerve fiber layer defect. One can look at localized rim thinning and notching right here. You can look at this notching right here. That becomes pretty obvious. So now let's look at the features of a normal nerve fiber layer. The normal nerve fiber layer, the thicker one, is brighter. You can see this brightness all along the edges. The optic disc has purposely been defocused. The texture, the bundles are separated with striations of glial cells, and therefore you can see this texture. And there are sometimes very thin slits that are thinner than the blood vessels, and they are normal. The blood vessel walls are indistinct. You can't make out these blood vessel walls very clearly. It is best seen, this nerve fiber layer, using red-free light. So I encourage everyone to use, in anybody who has been dilated, the green light of the slit lamp with the help of a 78 diopter lens. And you can visualize the nerve fiber layer very nicely. You take a look at 100 patients and you will be able to identify the nerve fiber layer even in an undilated examination. These nerve fiber layer defects that we are looking for are best visualized within 1 disc diameter from the disc margin, but that is old thinking. You can see these nerve fiber layer defects anywhere in the posterior pole. There are 2 categories. They are wide, that are approximately 3 to 4 major vessel widths, or they're diffuse. Here is an example of a diffuse set of nerve fiber layer loss. You can see what is normal, you can see the texture, and you can see what is diffuse. In diffuse nerve fiber layer loss, an easy way to identify is when the blood vessels look like pipes sitting on top of the sand, as if it's an oil pipeline that is going over a sandy beach. You can see all this is atrophied nerve fiber layer. You can see that there is some nerve fiber layer here. And then there is the localized nerve fiber layer loss, which is much easier to see. And you can always try to identify where it is when you can see that there is thinning of the neuroretinal rim. But as I mentioned, there are visible nerve fiber layer defects, not necessarily just 1 disc diameter away. Here is a very subtle nerve fiber layer defect and one right here. What I want you to pay attention to is the fact that it is a 3-dimensional tissue defect. The blood vessel dips in and comes out. The blood vessel is going in and coming out. This 3-dimensional nature of the nerve fiber layer defect confirms that it is indeed a nerve fiber layer defect and not a striation. And this can be seen very nicely using a dilated exam and a 78 diopter lens. If you look at a stereo pair, you can see the same thing happening here in this eye, or in this eye right here. This is subtle, right down here. You can see the blood vessel going in and then coming out. Now, you might think that I've had one glass of wine too many when I start telling you about this three-dimensional effects. And I have some nice SDOCT images to confirm that it is indeed three-dimensional. And I encourage you to see it for yourself when you take a look at patients.
Can I just interrupt for a minute,
Sure.
Dr. Asrani? I am not sure the postgraduate trainees are aware how to view a 3D picture. Could you just explain to them? If you could just go back once, because I did it and it was amazing. I converged my eyes. I could see it, but I'm not sure whether they are aware that they can do it. It'll be great if you could explain to them. Thank you.
So, Vanita, I have stopped doing it myself. So I'm going to ask you to go ahead and describe it to them. But I want them to really learn how to identify it in a live patient. And you can see that when you have a dilated examination and a 78 diopter lens, and you're looking at each clock hour around the optic nerve. Then you can see this in 3D. But regarding image visualizations, I used to be able to do it. You hold your finger there and all that stuff, but now I can't. So Vanita, why don't you go ahead and tell them how to do it?
Right, okay. So basically, I don't know whether you can see me, see my eyes clearly or not, but basically, if you put your finger, converge to the tip of your finger, and then take your finger away and keep looking at the images behind you, you will see a converged image of the two. And you'll be able to see a 3D view of the disc. Try it, all of you hot seaters. Could you do it? Take your finger away after that. Keep converging. Don't let your eyes diverge at all.
Yes, ma'am.
It takes a little doing, but you can do it. Yes? Piyushi? No? Didn't get it?
So Vinita, the images which are being shown,
Yeah.
they have to be some special images to be able to...
Yeah, they are captured 1 to 2 degrees apart, 2 separate images.
So that means that the capture has to be specific, then only you can do this.
Yes, yes, yes.
Yeah, the 5 degree apart, 2
5
images.
Okay.
Yes,
So
with the fundus camera.
Doing it as yet.
Huh?
It's not easy. It's not easy. That's why I said
Nobody is
I'm
doing
not
it.
going to even attempt to do it.
I'm seeing it beautifully.
No, that's
I
fine.
know, Vanita. That's because you are so young. You
No,
can do
not
all
at all.
these things.
Not at all. Not at all.
Let's go ahead.
Let's move
No,
ahead.
actually,
Yeah.
yes.
Sorry to interrupt.
Special
No,
lenses
no.
are available. With that, you can view it very comfortably 3-dimensional.
Yes, yes, yes. For
They
old
help
people
you
like
to
us,
converge.
those lenses are necessary.
Yes, absolutely.
Let's talk about this image. You can see this disc, and that you can see this very focal nerve fiber layer defect. But in this very early nerve fiber layer defect, you will be extremely lucky, or it is extremely rare to find such a focal nerve fiber layer defect associated with a blind spot, that is with a scotoma. And this happens when the defect is very deep. The optic nerve, the nerve fiber layer loss is very deep. When it is very deep, you get a field defect. But when it is superficial, it is not associated with a field defect. I do also want everyone to pay attention to the fact that these discs, like this one, or the previous one, or the previous one, or the previous one, they all look healthy and normal. So if you're only paying attention to the nerve, you will miss these early nerve fiber layer losses, sometimes which are associated with field defects. Now, this is a very good example for all of us to remember the topographic correlation of the clock hours versus what you will see in visual field losses. Now, this patient, one of my fellows said, oh, he has 2 blind spots. They missed on the field testing. It is only when I showed him the nerve fiber layer loss that he said, oh, this is the scotoma. So this is the topographic correlation that everyone should keep in mind. The superotemporal aspect of the optic nerve corresponds to a field loss right down here in sector 2, inferotemporal up here, the gray, that is the temporal in area 1, nasal in area 4, and of course 5 and 3. While we are on this slide, I'd like to elaborate a little bit on the types of field defects that allow us to detect the kinds of glaucoma or the optic nerve pathology. So when one sees a defect right here in the extreme areas of area 2 or 6, that is nasal steps and wide arcuate losses, those are classically associated with high pressure glaucoma. Whereas if you see the defects closer to area 1 for both areas 2 and 6, that is very classic of low pressure glaucoma. If you see a field defect in areas 4 and 1, it is typical of non-glaucomatous optic atrophy, usually neurologic. If you see field defects in number 5 and number 3, those areas are typically associated with retinal pathology or optic disc drusen. So this is something that one must commit to memory because you need this in the clinic. I'd like to point out some additional features of the nerve fiber layer defect. Sometimes major retinal blood vessels are sitting within the nerve fiber layer defects. That is, the nerve fiber layer has thinned out on both sides of the blood vessel. In such nerve fiber layer defects, it is not easy to find them. And especially if they're deep, they are going to be associated with the field defect. And then you'll be wondering, what's that field defect from? These nerve fiber layer defects can sometimes be detected near the macula. You can see this nerve fiber layer defect here, and you can see this blood vessel going in and coming out. You can see all these blood vessels climbing out of the groove right here. You can see how this is very close to the fovea. This is typical of low pressure glaucoma. This is typical of high pressure glaucoma. But we do need quantitative methods to measure and detect change, because by just looking at this in follow-up visits, it's not easy for us to say, oh, something has really changed or not. So we have had a plethora of instruments, such as the GDX or the nerve fiber layer analyzer, that used retardation effect of reflected laser light secondary to the polarization of the nerve fiber layer. This was fraught with artifacts because of the cornea being one of the biggest polarizers of light. Then came the Heidelberg retinal tomograph, that is essentially a confocal laser scanning ophthalmoscope. It scans the surface of the nerve fiber layer and the disc and the cup and identifies a arbitrary plane temporal to the disc, and then anything below that is cup, anything above that is rim. This, of course, is again fraught with some artifacts. Then came optical coherence tomography. Optical coherence tomography is essentially light ultrasound, multiple A scans of light being sent across the retina. And you can, initially, we could do it with 128 lines. Then it improved to 512 lines. But it was all dependent upon a mirror that was vibrating in the machine. Because it was a physical mirror that was vibrating in the machine, it was limited to 512 scans. You couldn't do many more. Then somebody came up with the idea that let's replace the mirror with a spectrum that it can be compared against, so we don't have to rotate the mirror. And this person was kind enough to publish the results without patenting it. And therefore, instead of having only one manufacturer of time domain OCT, we thankfully now have multiple manufacturers of what is called spectral domain OCT. This is time domain OCT with the nerve fiber layer measurement around the optic disc in a circle of 3.4 millimeters compared to a normative database here for the left eye, here for the right eye, them being compared. And you can see this nerve fiber layer. And this is the result that we would get typically with what is called OCT3. This was the time domain OCT. Then came spectral domain OCT, as I mentioned. And here is an example from Spectralis Heidelberg. I do want to mention, once I mention the word Heidelberg, I do receive lecture honoraria from Heidelberg when I give lectures, when they sponsor the lectures. Otherwise, I have no other financial interest. Here is an example in the right eye of an inferotemporal nerve fiber layer defect. You can see that loss in the profile of the nerve fiber layer. You can see it as compared to the normative database. You can see it on a color fundus photograph. And the same thing in the other eye. This image out here in the corner is again an image using scanning laser ophthalmoscopy. It is not just a red-free image, but it behaves like one. So you can use it to detect nerve fiber layer defects. In fact, you can see it right here. I want to share with you one more thing, and that is what is the strategy of the Spectralis, because it is different than the strategy of the other machines. The strategy of the Spectralis in measuring nerve fiber layer is 768 points of measurements in this circle. And then those points are laid out for you as a ribbon, starting from the temporal, going all around like this and coming back here. So this is here, this is here, and so on and so forth. Whereas the other company that makes a spectral domain OCT, which is the Zeis instrument called the Cirrus, they have a raster measurement. They do multiple lines, 200 by 200 protocol in a 6 by 6 millimeter grid around the optic nerve. And then they extract the thickness in a circle, 3.4 millimeters from the disc, 256 points. And they lay it out as a ribbon here for you. But because they have a raster, they also can give you a map of the display of the nerve fiber layer and compared to the normative database. So on the left eye, you can see this is a near normal nerve fiber layer. What you can see is on the nasal side, there seems to be a loss. But otherwise it is normal. And you can see it's plotted here. But what is plotted is only the circle. And in the right eye, it's significantly abnormal. So why am I giving an hour lecture on nerve fiber layer? Because diagnosis of early glaucoma is difficult. Variation between normals in axonal counts ranges between 500,000 or 5 lakhs to 1.2 million. And thus there is a large overlap between ocular hypertensives and early glaucoma, because you could have 500,000 and still be normal, and I could have 1.2 million and still be normal. Our optic disc rims would look quite different. It could look the other way. I might have 1.2 million, but a large disc, and I might look like a glaucoma suspect, and you might have only 500,000 in a small disc and look completely normal. one must remember that the convergence point of all the axons is in that optic disc. That is from, I wanted to show this picture because this picture shows you the extent of the entire retina from where all the axons are coming into the small optic nerve from where it goes to the brain. And when we look at our macular area, it is only this area right here. So look at the amount of retina that is surrounding this. So this is the convergence point, that is the nerve head and the peripapillary nerve fiber layer. So it may not be the best or easiest place to look for abnormality because it's a convergence point. Should we be interested in the macula? Of course, that's where the real problem is. The ganglion cells are dying, which is now reflected in the loss of axons or nerve fiber layer, and therefore reflected in cupping because the neuroretinal rim is thinning. Ganglion cell layer in the macula is multi-layered, and along with the nerve fiber layer thickness constitutes 40% of the entire retinal thickness. Also, the majority of the entire retinal ganglion population is in the macula. Let's go back to this image. 50% of all the ganglion cells in the retina are sitting here. The remaining 50% are everywhere else. Why is this? Because of evolution. We need this to be the sharpest vision. This is the central 20 degrees, where 50% of our ganglion cells are residing, but the visual field is not sampling the macula adequately. It is less sensitive to ganglion cell losses in the macula. There are only 12 out of the entire 54 points in this region. The macula in relation to the visual field, there are 230 ganglion cells for this one spot in the Humphrey visual field here, compared to 35 here and 10 here. So if you get a field loss right here near the paracentral region, that eye has lost a lot of ganglion cells, because the visual field loss doesn't happen until the last layer of the multi-layered ganglion cells has died. As long as there is one layer, that layer will pick up the visual stimulus for the other layers compensating as a redundancy because of evolution. But once you get a black square here, that tells you you have lost a lot of ganglion cells. Whereas here, if you get a small nasal step, it's not that much of a loss. This area where the ganglion cells are sitting, the variation is extremely small between you, me, anybody else. The total number of the ganglion cells, as I mentioned, can vary between 500,000 to 1.5 million among normals. But this area doesn't change between patient to patient. One needs to lose almost 70% of their ganglion cells in the paracentral region to create a 3 decibel loss in the field, compared to only 44% of the ganglion cells in this peripheral region. And the reason being that in the peripheral region, there are only 1 or 2 layers of the ganglion cells, whereas in the central region, there are 6 layers of the ganglion cells. Now, the macula was initially not looked at because nobody knew what was normal macular thickness. In the 1990s, we created the first map of a normal retinal thickness using the retinal thickness analyzer. And then we found that actually you get a lot of losses in the macula, deepest further away from the disc, because the ganglion cells are lost in glaucoma, and therefore the loss of thickness is greater further away than closer, because the ganglion cells are 35 microns in diameter, Whereas the nerve fiber layer, one axon is hardly 1 or 2 microns. So if you lose many layers of ganglion cells, you can have a lot of loss of thickness compared to just axons being lost. This is what the time domain OCT did to detect a macular thickness map. Some places still have time domain OCT, but I want to let you know that if you do look at time domain OCT maps, this is just a interpolation of data, because data is collected only in 6 lines, and the space between the lines is filled in by an imagination of what the data could be. You can see how many times the patient has moved by looking at the edges of the fovea. The foveal pit is never scalloped like this. This tells you how many times the patient moved while this eye was being scanned. Also, I'd like you to look at the color scale. The color scale changes every 100 microns. That means for you to detect loss of tissue, it would take you 100 micron loss before you can see changes in color. In glaucoma, 100 micron changes don't take place. 10, 20 microns take place. In retinal diseases, 100 microns will take place. So what we did is, working with the Heidelberg people, I created a macular thickness map in the entire posterior pole that corresponded to a 24-degree visual field. We changed the color scale such that there would be multiple changes of colors depending on 25-40 microns. And we use the entire retinal thickness from top to bottom, because it is easiest for the machine to identify this layer and this layer rather than trying to identify shades of gray. And of course, we used eye tracking for excellent reproducibility. The problem was there was no normative database. How do we know that what we are seeing is normal or abnormal? So we took advantage of symmetry in nature. Everything is symmetric, so even the macular thicknesses are symmetric. And therefore, any slight asymmetry is very easily identifiable. We created an asymmetry display between the two eyes. That is, we subtracted the right minus left and left minus right, and we put a scale of 0 to 30 microns, black being 30 and white being 0, of difference between the two eyes. We also created a hemispheric asymmetry, but this should not be paid attention to because many discs are tilted. This was created only for the sake of monocular patients. So let's see some examples. Enough of didactic. Keep in mind the nerve fiber layer scan considers the peripapillary region, which is the convergence point. So focal losses like this one here, right down here, get averaged out because the rest of the measurements are normal. So therefore, the average in that sector will be normal. And if you look at only this green report, you'll get fooled and miss this very focal loss of nerve fiber layer. But if you do macular thickness along with the nerve fiber layer thickness, you are not going to miss it. You can see very clearly that there is this focal loss right here that corresponds to this nerve fiber layer loss. So one must use both to be able to diagnose glaucoma, and as I will show you later, to follow glaucoma. Here is an example of a glaucoma suspect within normal visual field. One can see there is an asymmetry between the two eyes. Oh, by the way, this program of posterior pole thickness and asymmetry is available on all Spectralis machines at no extra cost. So if you have a Spectralis machine, you can do this. It's called the posterior pole map. And I did not want to name it Asrani map because I didn't want to get a bad name like Alzheimer's disease or something like that. So this is the posterior pole map. You can see here, this is the asymmetry. You can see the very subtle loss right here in contrast to the other eye. You can see this three-dimensional layer of the nerve fiber layer being lost. You can see the blood vessels dipping in and coming out. You can see that focal loss here. You can see it on the color image, the blood vessel dipping in and coming out. And you can see this on the SLO image also, right here. Mind you, because it is focal, it's still within normal limits, but that is the sector average that is within normal limits. Just because the sector average is within normal limit doesn't mean it's really normal. This is the three-dimensional reconstruction. You can see that very clearly, how the blood vessel dips in and comes out. Here is a moderate pre-perimetric nerve fiber layer defect. You can see that here. You can see that right here, right down here. What I encourage everyone to do is, rather than looking at these green and pink and red areas, the first place one must look at is the asymmetry between the two eyes, because the two eyes are plotted here. This asymmetry feature is present in all machines, starting from the GDX to Cirrus to OptoView. Every machine has an asymmetry plot. Wherever you see the right and the left eye separate, that's where the glaucoma problem is. Because remember, asymmetry is the hallmark of glaucoma. After all, what do we talk about? Cup to disc asymmetry, everything asymmetry. So look at asymmetry and you can see the difference. I'm not saying that this left eye is completely normal, because you can see it's starting to thin out here too. And if you look at the macular thickness of this patient, you can see this loss right here, corresponding to this focal loss down here. You can see that loss. And you can see that the internal limiting membrane has not yet collapsed. Here is a near normal field in the right eye, a significant field loss in the left eye. So we were treating the left eye aggressively, but we were not treating the right eye so aggressively in terms of target intraocular pressure. But when we did the macular thickness, we realized that, yes, this in the left eye was, as expected, a significant loss, but even in the right eye, there was a significant amount of loss. So therefore, we lowered the target pressure of the right eye as well. And of course, the holy grail is detecting progression and switching off your Humphrey visual field, right? If you can avoid doing visual fields, not only you are happy, even your patients are happy, your technicians are happy. Because it is so difficult to do that test as well as to interpret that test. So let's see if we can detect progression using OCT. As long as we have a reproducible OCT machine and measurement, we should be able to detect progression. How do we do that? Here is an example of progression. This is the baseline image on the top, which is from March 2010. This is the profile. This is 2011, April. This is 2011, September. And the April is subtracted from the top, and then the September is also subtracted from the top. The top is the red rectangle, which is the baseline. So you can see here in the inferotemporal region, there is a big change between April and September. Right here, the pink area is the difference between the two visits. And you can see not only there is a small subtle change superotemporally, but also inferotemporally. And you can see that in the profile thickness. If you look here, you can see it thinning out. You can also see it on the macula. This is that April visit. This is the September visit. And you can see this red arc, which is the difference between the baseline, which is the red rectangle, and the next one. And you can see the difference And this difference is about 25 microns in thickness in 6 months. So within 6 months, you can see these losses. It takes years for it to show up on the visual field. But with the confirmation between RNFL and macula, you can be sure that you're dealing with glaucoma progression. Here is that same patient who kept worsening, kept losing tissue over time, despite the best of management. Artifacts. Remember, the machine does not have a brain. We have to use our own. This is a patient who had a complete loss of the nerve fiber layer. I told them to repeat the measurement because I suspected an artifact. And lo and behold, the measurement became completely normal. How does this happen? This happens because the technician did not bring the image into the center of the window and chopped off the nerve fiber layer on the top. Told her, do it correctly, and there, lo and behold, the nerve fiber layer is normal. How did I know that this was an artifact? One is that measurements never drops to zero. There is always a floor effect. So if it drops to zero, something's wrong. Also, there cannot be an absent nerve fiber layer when I can kind of see the rim and I can even see the nerve fiber layer here. I can see the striations. So I know there is nerve fiber layer there. So that's how I detected that it is an artifact. Then there are some artifacts that come because of vitreous floaters. Thankfully here the software bridged this, but otherwise the software would have dropped it down to zero because there's nothing there. And that's because it's a shadow artifact. You can also see an epiretinal membrane distorting the nerve fiber layer. So let me ask one of the residents. You can see this patient in July 2012 had this loss. This is that same patient I showed you first. This is the loss. In October 2012, this loss had disappeared. Not only that, there was an increase in nerve fiber layer thickness. How does one explain this? You can see it here. You can see there was tissue loss and now regrowth of that nerve fiber layer. Any of the residents who are live?
So if there is any media opacity, maybe the patient has developed cataract over time and is
but it wouldn't be focal, no? It wouldn't be focal.
Sir, any
Cataract
edema
would cause a global distortion. There would be the quality of the image. Beg your pardon?
if there is any edematous edema accumulation in that area, which increases the thickness of the nerve fiber layer.
Very good, very good. I'm glad you have read up something about it. Any other possibilities? So it can't be retinal nerve fiber layer edema from inflammation because it is very focal. You don't get focal edemas in inflammation. How can this patient regrow nerve fiber layer? Anybody? Doesn't have to be a resident. Rolika? Any ideas? The reason is there is a disc hemorrhage right here. Disc hemorrhages cause a swelling of the nerve fiber layer. And therefore, it looks like it regrew. Of course, at the next visit, it will be even thinner than the baseline visit. So any swelling focal in the nerve fiber layer will appear as reversal of nerve fiber layer thinning, such as disc hemorrhage and such as cotton wool spots. This is an example of a patient who seems to have progressed. This progression, you can see here the baseline, 2010, 11, 12. You can see a lot of thinning, but this thinning is not real. You can see that there was a tug on the internal limiting membrane that slowly resolved over time. And it looks like progression, but you have to look at the raw image to confirm that is that real or not. Here is an example of a vitreous that is tugging here. And a year later, that vitreous has separated. A posterior vitreous detachment has occurred and it has separated. And therefore, this is now much thinner. It looks like progression. And this is what one of you, I think, was it Shruti or Sanjana, I don't remember, described in uveitis, how this nerve fiber layer seems to have grown. So you can see a lot of green is because this patient who had a total cup developed uveitis and now developed nerve fiber layer edema. So use OCT with extreme caution in anybody who is post-op, within 6 months of surgery, within 6 months of an intervention, and or has uveitis. Remember that in myopic discs, you get this severe peripapillary atrophy. So you can ask the technician to purposefully decenter the ring to get a better measurement and avoid peripapillary atrophy. Even though you get a lot of artifacts and the measurements drop to 0, even though the measurements don't conform to the normative database in myopes, you can use the raw image to tell you that the superotemporal and the inferotemporal bundles seem to be in near normal thickness. But then there are certain myopic nerves like this one, where it is a posterior staphyloma, so the entire nerve cannot even be brought down into the entire window. And there is so much schisis of the nerve fiber layer that you cannot use nerve fiber layer OCT in these extreme myopes. But you can use macular thickness, because the macular thickness, if it is normal, it tells you that most likely the visual field will also be normal. Let's look at some other imaging modalities like multicolor imaging. Multicolor imaging is an image that uses 3 lasers to get an image, red, infrared, that is, blue and green lasers, to create an image of the retina. And this is multicolor imaging. You can see every layer of the tissues, and you can see each and every axon bundle. And you can see the horizontal raphe. And you can see this excellent detail of the nerve fiber layer. So now you'll be asking, what benefit is this? If I can see each and every bundle. You can't quantify it, but there are times when your OCT measurements don't conform to the normative database. And then you're left wondering whether there is real loss or not. For example, this is a 6-year-old patient who came in as a glaucoma suspect because of very large cups. With multicolor imaging, we were able to see the nerve fiber layer, and not only see it, but also document it to confirm that there is absolutely no loss and that this is physiologic cupping, saving this patient a lifelong grief of being under treatment. Here is another example of a very large cup in a very large nerve, but once again, completely normal nerve fiber layer. This is a way of nicely documenting the nerve fiber layer. Even if you don't have this instrument, which many of my colleagues don't have, what I want to teach with this is that you can see this nerve fiber layer clinically. And when you can see it clinically, you can at least reassure the patient that you can't see any nerve fiber layer losses, even though the OCT of this may be completely abnormal. Here is an example of glaucoma with the multicolor imaging. You can see the losses right here. The nerve fiber layer losses are very nicely picked up with multicolor imaging. You can also use the multicolor imaging for patients with retinal pathologies like branch retinal vein occlusion. You got a lot of edema in the retina, but when you look at multicolor imaging, you can see this nerve fiber layer loss here. You can see this nerve fiber layer loss here. But I must caution you, this may not be glaucoma. This could be from an old cotton wool spot in this region or in this region that resulted in this nerve fiber layer loss. So in conclusion, glaucoma diagnosis is made a lot easier with multicolor confirmation of either clinical findings or OCT findings. Confirmation of the absence of glaucoma by visualizing the normal nerve fiber layer is possible using clinical exam and multicolor. Diagnosis of coexisting pathologies must be kept in mind. Always combine the potential of nerve fiber layer and macula in diagnosis and follow-up. Thank you very much for your kind attention. I think that was just completed in time.
Yes, amazing.
That was exceptionally eloquent. Step by step.
I don't know how many people fell asleep, so I put that last slide up there.
Oh, not me.
No,
Right. Dr. Maipal Sachdev wanted to say a few words before we move on for discussions. I think he has logged in.
Good evening.
Hello, Dr. Sachdev.
Hi, how are you?
I'm good, thank you.
So your video is off.
Yeah, I know. Just give me a second.
Thank you, Dr. Asrani, for your wonderful talk and the time that you spared for us.
My pleasure. Happy to help.
Yeah. Thank you very much, Dr. Sanjay Asrani. It's really great that you pitched in, and I am sure that the session must have been a great session. Dr. Pradeep, Dr. Harsh, Santosh, and Dr. Vanita and others. Well, it's indeed a pleasure to say that this is the non-stop 100th episode. So that is the one of the milestones that we had ever since we had the COVID situation coming in, since we could not have the iFocus, which we usually had for about 7 days or in the physical format. So keeping in mind that the need for the residents is all the more acute, and the younger generation all the more acute for keeping the learning process on, we had decided to do the iFocus online. And every Wednesday, Friday, we have been doing it. And today is the 100th episode. And thank you very much, Dr. Asrani, for being the century maker for the iFocus this time. And we have finished cornea neuro-ophthalmology, and now we are going on to glaucoma as things stand. We would appreciate a good feedback from all the people, and the number of viewers and subsequent citing on the Facebook and the YouTube has only increased over time. And I think we would love to have feedback from all the people as to what exactly are any shortcomings, if at all, and how we can improve the whole thing further. And I wish to also thank that Dr. Santosh has been it has been his brainchild ever since he came in and joined Center for Sight, and he's one of the great luminaries along with Dr. Harsh, Dr. Pradeep, Dr. Vanita, who are part of the Center for Sight. And we have actually kept continuing medical education in the forefront of one of the activities that Center for Sight is doing. So all that I'll wish to say is that we are indeed grateful to all the teachers, all the people who have participated so far, and those who are going to participate in future, as also the people who are administering it or who are helping us go online, and obviously Santosh and his team for putting this all together. So congratulations, Dr. Santosh, and congratulations everyone. And I think it's a great milestone that we have had an uninterrupted stint twice a week over the last several weeks and completing 100 episodes. So we have had international speakers also, and even today we have an international speaker in Dr. Asrani from Duke. And I think the enrichment of the ophthalmologist in India has been enormous. And I think we will continue with our efforts to make the ophthalmology levels and the standards as good, if not better than anywhere else in the world for all to emulate. So thank you everyone once again, and I think it's a great honor to have you again, Dr. Asrani, as the 100th speaker in the 100th episode. And great work, Santosh, and all the very best and happy learning. And I would say stay safe, everybody, in this pandemic, because we are still not away from it. And this time we have the younger people also getting involved. So get vaccinated, stay safe, and keep learning during these difficult times. Thank you.
Thank you, sir. Thank you for your support.
Can I just add a few words here? I feel this is such a valuable resource that is being created, which can be viewed by the trainees in their own sweet time. I mean, the physical iFocus was so intense over 7 days that absorbing everything could have been an issue. I think after the first or second day, everyone starts feeling fatigued. But here they are in their own time. They can go through the lectures. They don't just have the presentation. They have the presenters talking as well. I think it's so valuable. I wish I had something like this when I was training. Honestly, I mean, and even now, you know, sometimes I go back and see a few episodes which I feel that, you know, I would like to refresh my knowledge in. So hats off to you, really, honestly. Thank you very much. Right, so back to the talk now. There is a very obvious question, but can I just ask you one question, Dr. Asrani? And that is, when we are doing Spectralis, there is this issue of marking out the BMO. And how does that differ? Because I think there are many more Zeis, Cirrus SDOCTs available here, and perhaps even the OptoView, but not so much the Spectralis.
I'm fully aware. Very good question. So I'd like to just share some broad thoughts about what I spoke about. I may have shown you many examples of Spectralis, because that's the instrument I actually helped develop software for. I work with them, but besides that, I have no financial relationship with them. But these principles that I shared with you about the artifacts, how to see the nerve fiber layer, how to use the combination of nerve fiber layer and macular thickness together, is applicable to all instruments, all machines. So you can use the OptoView, you can use the TopCon, whatever you use, these principles should help you analyze those images, look at those images, and look at clinical patient examination. The other question you had was about the BMO.
Yeah.
The BMO is something that I currently do not utilize.
Okay.
It is one more tool in case the surface nerve fiber layer is corrupted by epiretinal membrane. Then the BMO becomes valuable. But otherwise, I'm not finding it's adding a lot of potential. So therefore, to conserve time in the clinic, instead of getting so many measurements that I don't know what to make of them, I just use RNFL and posterior pole macula.
Right.
And that's all.
Okay,
and that's why I don't use the BMO.
That's great to know. The reason I ask this is because of the resource that is being created by Professor Chauhan and Jamie. And, I just, I did the 200 discs. I flew through the ones that had Cirrus and and OptoView, but Spectralis, I had to just hang on, and there were difficulties. There's no doubt.
Yeah, BMO is not my brainchild. BMO is there is a long history on that, and just for the entire audience, BMO stands for basement membrane opening, or Brooks membrane opening, minimum rim width. So it's BMO MRW. It's a software that measures the minimum rim width at the edge of the optic nerve to know how much is the neuroretinal rim. It is also subject to artifacts like disc drusen, like epiretinal membranes, severe myopic discs where the software is unable to identify the end of Brooks membrane, things like that. So it is one more tool that one can use if one is getting that as a measurement. But there is only a limited time that a patient is going to sit comfortably in front of the OCT, and that you have in the clinic, because you have to move patients through. So if you do a lot of imaging, a lot of testing, you're going to get delayed.
Right. If you have a few more minutes, then we take some reactions from our chair and our rolling chair and co-chair, Dr. Harsh and Dr. Pradeep. And then there are a few questions as well.
Sanjay, I think it was really, really wonderfully done, and it really opened our eyes to the central part that you showed, and the way you showed it was so wonderfully done. And
thank you.
What is your opinion about the OCT angiography? Is it really helping us detect things earlier? Or
no.
No. So it's pretty much
one word answer.
Fair enough. That's because there's a lot of,
and I'll tell you why. No, I can elaborate why. Yeah. The reason is that the OCT angiography is going to be useful when you do a large area in mapping of OCT-A. We have done that. Before the machine was released to the public, we were able to do that to test. And we found that it took so long to do it. And the patients were moving, the eyes were moving. Remember that per second, the eye moves 5 times. So if the eye is moving 5 times per second, and it takes them 45 seconds to do that, you got so many artifacts that what you're seeing is not truth. Also, they haven't been able to remove the projection artifacts, that is the superficial layers project onto the deeper layers. So until that software improves, it has limited potential.
So that is a problem. When they bring up a new machine, they always bring out people to tell us that it is very, very good. But I think that is very nice.
That's why you want somebody who has no financial interest.
Right. Exactly. So, Dr. Pradeep.
Yeah, that was fantastic, very rich talk, Dr. Sanjay. Congratulations, and we learned a lot. Obviously, I always says that, whatsoever you see, OCT cannot document more than that, because if you do a thorough clinical examination, you can pick up even the smallest RNFL defect. But OCT is useful, as I used to say, that for documentation and for monitoring the disease. But today you have shown us the beautiful thing of the posterior pole image, that there are 238 ganglion cells in the posterior pole, and that can be picked up by the Asrani image, and that obviously my eyes
don't
cannot
call it
see.
Asrani image. I don't want to become another Alzheimer.
No, you become another Dua. Dua is there.
Nahi ji, nahi. Dua hai bas.
But it was amazing, on subspecialty day of this virtual American Academy, I saw that photograph 2-3 times, and it was fantastic, beautiful, amazing. So congratulations to you, and we learned a lot. That not only I can say.
I'm glad I was able to help, and thanks to Santosh for reaching out and asking me to join, and I thought this would be a nice way for me to give back especially when there is COVID. And congratulations to all for making 100 such episodes happen. That's impressive. That's impressive. The coordination that it must take, and for each of you to, or at least most of you, to come online twice a week to listen and go through this. My goodness, congrats.
Right. On that note, can we take a few questions? Hello.
Anybody having questions? Vanita, you have a...
Yes, there are a few questions.
Yeah.
So between GDX, OCT, and HRT, which one would you prefer?
Hands down OCT, because the GDX and HRT are surrogate measures of tissue. They measure something and interpret them as tissue changes, whereas OCT gives you the actual tissue measurement. And therefore, OCT hands down is the best way to go. And that's why the other machines are not much in use.
Right.
They are not available also. The manufacturer have stopped manufacturing them.
Right.
Yeah, I mean, and also OCT has the advantage of it being so useful in the posterior, for other retinal diseases, as well as in the anterior segment. So it's way more versatile.
Yes, it is a very useful tool because OCT can help you diagnose neuro-ophthalmic conditions, brain tumors, the speed at which the brain tumor is growing, the potential for a person to recover vision once the brain tumor is removed, or is there no potential? There is so much more that the OCT can do.
Yeah, sure. And there is another question which says, if disc, and this is asked quite often around here, because I think it is practiced very, the practice is very, very widespread, that if disc and visual field are normal, but OCT shows RNFL change, do we start patient on treatment?
Great question. The optic disc will look normal until the neuroretinal rim has significantly thinned out. And the larger the disc, the more difficult to assess the neuroretinal rim. The smaller the disc, the more difficult to assess the neuroretinal rim because the change is so subtle that you can't pick it up. So the disc is going to be normal. Now, visual field, of course, is going to be normal until you have crossed the mild stage of glaucoma. So you can treat once you reach the moderate stage in patients who are older, but patients who are younger, patients who have a family history of glaucoma, patients who have a family history of having gone blind from glaucoma. Those patients, I would recommend treating at a mild stage, which is when the OCT is abnormal, but the field and the disc are appearing normal. However, the caveat is that you have to be sure that what you're getting from your OCT machine is free of artifact, is free of other masqueraders that can look like a BRAO, a branch retinal artery occlusion in the posterior pole will masquerade like a classic glaucoma. There is a field defect, there's an arcuate loss, everything will look like glaucoma, but it will not progress. So if you're not sure, repeat it in 6 months. And if it has changed, then you know you're dealing with a disease or condition that is changing. Sometimes there is old glaucoma. Somebody may have used steroids in the past, pressures may have gone up, nerve fiber layer got lost, but now there is no active glaucoma. So there could be so many other possibilities that one cannot give a sure answer for this.
Bottom line is that, if there is a doubt, one must look for progression because that's the hallmark of the disease.
Absolutely.
But I feel people feel the pressure to diagnose on the day, whereas actually it is patients that will answer that question. Any comments, Dr. Harsh, Dr. Pradeep?
Yeah, I think very rightly said, Vanita, that like Sanjay had already told you, if you're sure there's no masquerading over there, but still if the history is plus minus, the family history is not there, the pressures are borderline, you're not really sure. I think what you said was that we have to wait a little bit more, make sure that you are getting two things. First of all, you have to have two OCTs which are symmetrical. Even the defects have to be same, so that
on the same machine.
Yes, on the same machine with this, and if possible with the same operator, because even that sometimes changes things. And then Obviously, if you are having those two, and if the family history, etc., is positive, maybe you can go ahead and treat. But yes, because nothing is going to be so rapid in this case, you may just wait, see a little bit of progression, and then be 100% sure.
Any comments, Dr. Pradeep?
Nothing is foolproof. Probably, your eyes and brain are the best judge. And also, we know that the OCT resolution is also the 6 micron. And many a time, it's almost 15% ganglion cells are lost, then only the OCT would be able to pick up the defect. So even the OCT cannot pick up the very, very early changes or very early defect. Yes, the OCT can pick up before the perimetry, but it is also not very early. So OCT also not foolproof, but at some point of time, yes, you feel that OCT is evolving very fast and are collecting good normative database and in various ethnic population and various subgroups like, moderate myopia, high hyperopia. So I think, once we have a good, normal, robust database, then I think the OCT would be a better choice.
Right. A comment is coming in right now, sorry to interrupt, which says that if OCT shows changes and GCC is normal, that of course being the, then do we take this into consideration? It should be the other way around, isn't it? We should be worried more about the macula if it is abnormal compared to peripapillary.
This is a very good question, and this is a constant source of controversy here in the US also. Keep in mind that the GCC is measuring only 3 millimeters of the posterior pole in the Cirrus. In the Spectralis, it is measuring 8 degrees, whereas in the Cirrus, it's only 3 degrees. So if there is no paracentral loss of ganglion cells, it won't show up on the GCC. If you use the Spectralis, you can see the losses anywhere. So whereas in the Cirrus, there is only a central area that is being measured. So having said that, keep in mind that both must be artifact free. Secondly, if there is an RNFL loss that is real, it has to show up on the macula. Otherwise, it is not real. Because it's the same structure. It's the ganglion cells that are dying, which is causing the nerve fiber layer, which is its axon to die. The problem is that if the axon bundles are dead, and you can detect that, that means definitely you can detect the change in thickness in the macula, because the ganglion cells are 30 times thicker than the axon. So it has to have a corresponding loss in the macula. But you have to make sure that you're looking at the entire macula to be able to confirm. Because in low tension glaucoma, where there are paracentral nerve fiber layer losses, you will very easily see changes on GCC. But in high pressure glaucoma, because the changes are in the peripheral nerve fiber layer, you may not see it early in the GCC.
Sure. And in that context, there is a question which says, explain red and green disease. I think you gave ample examples of green disease. These are the kind of questions that are put in exams, as Dr. Harsh is smiling. Would you like to take that up?
As you said, I gave examples of green disease where there are focal losses and the average becomes green and normal. There are epiretinal membranes that will make the tissue appear thicker than what it is really. That means it will also be green, even though there is tissue loss underneath it. I also gave examples of green disease like uveitis, which will show thickening of the nerve fiber layer, which is actually not thick, but it's just swollen. So once you start the steroid to treat the uveitis, the nerve fiber layer will thin out because the edema is going away Not necessarily that the nerve fiber layer is getting thinner. So then the blame goes on the steroid. Oh, there must be a steroid response. So as I said, extreme caution in uveitis. Now talking about red disease, that is very, very common in myopes because the myopic bundles of the nerve fiber layer are more turned towards the foveal center. So they don't match up with the normative database. So typically everything is red. And those are the commonest causes of referrals to glaucoma specialists. So we have to look at, therefore my emphasis is on symmetry. If there is extreme symmetry between the two eyes, then it is very low likelihood of it being glaucoma.
That was also a question, by the way. What is RNFL symmetry?
Right. It doesn't have to be normal as long as it is symmetrical, because it is almost never symmetrical unless the patient has end stage glaucoma in both eyes or is really normal.
So RNFL loss due to any other cause, atrophies, etc., will also show up as a red disease.
Absolutely. But their red is disease.
Yeah, it is disease, but it's not glaucoma, I would say.
Yeah,
they are glaucoma. So you have to be very careful that you just don't label some optic atrophy, which is old time stable, and you label it as glaucoma and start treating it.
Absolutely. That is a very good point.
And even in the end stage disease, it's all red, and OCT is not useful in the end stage disease because of the floor effect.
Correct.
That is another problem. And even in the blind eye, because it recognizes the glial tissue as a healthy RNFL. So that's again a problem. You do a no PLI, and you will see that somewhere you will find that healthy RNFL is there. So basically, that is not the healthy RNFL, but that's a glial tissue. Is that right, Dr. Sen?
There is always a 30 to 40 micron tissue residual thickness of the astrocytes, which are the glia. Therefore, you will always see a little baseline, what we call floor effect. Therefore, I don't use RNFL OCT in advanced stages of glaucoma. I only look at the posterior pole macula, because if the patient has any vision, they have some ganglion cells in the macula. And their ganglion cells in the macula, there is some residual thickness that I can monitor. And if I have a machine that can monitor changes of 10 to 20 microns, I can monitor ganglion cell losses. It is not easy, but it is possible.
A question came in pretty early, and that asked to explain the alpha angle.
I don't really know what that means.
I wasn't sure what that meant either, but
whether I know. I really don't know.
Not in an OCT.
Not got anything to do with our topics here.
Right. Any further comments? Anything that you would like to add? We are so grateful. Honestly, I cannot think of anyone better to take us through RNFL than yourself, Dr. Asrani.
Oh, thank you. That's
been
very
a
flattering.
Pleasure.
It's
I loved your illustrations. They were wonderful. Your multicolor images are absolutely gorgeous. You cannot see a better RNFL. I mean, I'm a great proponent of taking photographs, taking red free, asking trainees to look through the slit lamp through a green filter, all of those. But nothing beats that multicolor imaging.
I would like everyone to become as skilled as possible to be able to view clinically the nerve fiber layer as good as that. So if we can achieve that, then we know if our machine is telling us the truth or not. And if the machine doesn't work, we don't need it.
That's a great wish.
Thank you.
I'm sure all of us here wish the same from our students, our trainees, our fellows, and so on and so forth. Any final words from Dr. Harsh, Dr. Pradeep?
I think it was. I just wished that he had named that layer on his name.
अरे यार नहीं पीछे क्यों पड़े हो?
No, for us to feel proud, not for
Oh,
you.
okay.
You have regrets, but he doesn't seem to have.
I don't have regrets.
But we all know.
I just look at it. I just look at it. Dua hai na. Chalo. Okay. Thank you, guys.
Okay.
Good night.
Thank you so much.
Bye bye.
Have a good day.
Bye-bye.
Thank you. And thanks here to our rolling chair, rolling co-chair, all our hot seaters, as well as all our attendees. And thank you, Dr. Mahipal Sachdev, for those encouraging words for iFocus Online.